Hello, everybody. This is Sarah DeSilvi. It is the top of the hour, and we have an incredible lot to get to today. Welcome to the Gravity Project Multi-Domain Concept Review for October 29th, 2020. We'll probably spend most of the full hour and a half today trying to get level set across multiple domains with an eye on crafting our collective ICD-10 CM admission for December 4th. Next slide, please. Again, welcome. For those of you who might be new, just some orientation elements. Due to the large number of attendees, everyone's muted upon entry, and we ask that you remain muted in order to avoid background noise. The call is always recorded, and it's available on the Gravity Confluence following the call. You're encouraged to actively participate. I do try to be very responsive to the chat. You'll also know that key links and action items are in the chat as we go along. So please send your chats to everybody, and we'll do our best to make sure that we're covering everybody's needs. Next slide, please. This is a common antitrust practices slide that we mentioned at the beginning of every call. Next slide, please. Again, if you're new, welcome. It's a pretty pretty dense day to come to the project for the first time, but we invite everybody on the call to officially join the project by following the link on the slide that's now in the chat. If you want to check up whether you've already signed up or if others from your organization have signed up, the Confluence remains a pretty great overview of these concepts. And again, the Confluence has been elegantly reorganized by our project manager, Carrie. And if you follow that, you can see links to both technical work and the domain work. And you can see all of the subdomain pages, updates, information on committees, etc. It's all there at the Confluence link. Next slide, please. A big thank you to our project founders, grants, and in-kind support. We are a growing community, and we're grateful for everyone who's contributed in the past and contributing going forward. Next slide, please. We are humbly always looking for additional sponsors. If you or your organization is interested in sponsoring, you can either just email Gravity Project directly or visit the sponsorship page on the Confluence for more information. Next slide, please. We are really proud to say that the submission for Gravity USCDI was submitted on time. Very, very grateful for all the insight of the collective, and you can find the letter on the Confluence at this link. If you have any further questions, let us know. We are definitely going to loop back once we connect with the ONC to see what next steps are. There usually is a bit of a back and forth, but very grateful to submit that USCDI with the leadership of Bob Dearly, our technical director, Mark Savage, our policy lead, one of our Cambia Grow fellows, and just very grateful for everyone who added insight. Next slide, please. Again, we want to mention that the HL7 STOH Fire ID public meetings are scheduled on Wednesdays from 3 to 4 p.m. Eastern Standard Time. You can see the meeting calendar by following the link. We encourage everyone to join. So if you are technically minded, that is the meeting for you. So here on this meeting, we try to cover everything for the public just to get a meta understanding. But if you have questions about issues of technical build, including everything from coordination or pre-coordination to consent, it's all happening in that little work group on Wednesdays from 3 to 4. So please do join if you're a technical person and want to contribute to the work. Next slide, please. Just a reminder to everyone on a regular basis, we try to remind folks that the Administration for Community Living Challenge Grant is now accepting applications. The letter of intent is due December 14th. There are some new updates that The applications are ideally referencing Gravity standards and our colleagues at Open Referral HSDS standards. You can find all kinds of information about the challenge grant at the link, and there's also a link to past webinars on the grant. Next slide, please. All right, you can see there's a lot of Sarah today. We have a very, very robust agenda today. So Evelyn or I will briefly go through the Gravity roadmap and upcoming domains. And then we are reviewing some brief updates for inadequate housing and then doing our first live vote to try to close out housing instability and homelessness and inadequate housing data sets. And again, close out doesn't mean never coming back. It just means that solidifying things so that we can get them into build and test them. Oh, so somebody has a question regarding how to get into those HL7 meetings. I'm wondering if we can connect with you through email. Maybe one of our colleagues from EMI can assist with that. And Marianne will definitely loop around with you. We're then going to cover, after the vote is closed, we'll go into some transportation insecurity concepts and financial strain and updates on education, veteran status, and employment. Again, this is to get everything in front of the community that we might be able to agree upon with that 12/4 deadline for ICD-10-CM in sight. Again, it's a busy meeting. We're going to do we're trying some new things today, and we'll see how it goes. Next slide, please. Evelyn, do you want me to just lead this? Is Evelyn on the call?
Go ahead, Sarah.
Okay. So again, we show this every single time, but if you're new to the call, this is kind of the meta domain view. You can see on the top is the terminology work stream, and on the bottom is the technical work stream, and then way down the bottom is our projection about doing the FIRE implementation guide pilots. Just a note on some of the bars here, because of our focus specifically aiming towards collating screening questions and answers and diagnoses for this last quarter of 2020. Some of the goals and intervention works on these concepts will stretch into Q1 of 2021, and that's just to make sure that we cover everything well. And you can see the interpersonal domains kick off in Q1 2021. And then we have our little parking lot about domains to be determined. You also can see that we're aiming again for that IG ballot in early Q1 21 in January. Next slide, please. Again, this is where we're headed. So our 2019 domain in food insecurity, and then our 2020 domains of housing instability and homelessness, inadequate housing, transportation insecurity, financial strain, education, employment, and veteran status, again, focusing on screening and diagnoses. Again, with all those diagnoses identified as necessary as part of that 12/4 ICD-10 submission. And then 2021, we have our choices. We can figure out what to focus on for goals and interventions, but basically continuing the multi-domain work and making sure that we get these domain data sets as robust as we can together. Next slide, please. Again, this is our just kind of waiting room of concepts that we know we need to address that we don't have on the timeline yet. Feel free to add things to this list if needed at any time. Next slide, please. So here we are. So we are doing, it's 10/29. We're doing our housing instability and homelessness and inadequate housing consensus vote. We're still actively asking for transportation concepts across all 4 activities of screening, diagnoses, goal setting, and interventions. Same thing with financial strain, and same thing with education, veteran status, and employment concepts. Understanding that if we are not addressing goals and interventions necessarily yet, we'll still just put them into submission spreadsheets and get everything tidy and ready to hit the ground running. Again, then we're kicking off education, veteran status, and employment, again, with that lean and mean look toward ICD-10-CM and screening questions and answers. And then next meeting, it's important. We're again trying to get a consensus diagnosis statement on in order to aim for that ICD-10 coordination and maintenance committee meeting. The submission is due 12/4, and then not on the calendar. There'll be a meeting in the middle of December to continue the work on goals and interventions after we take a breath with Thanksgiving weekend. Next slide, please. This is our meta slide on the intersection of our two work streams, terminology that I lead, and then the technical work stream that my colleague Bob Dieterle leads. We are actively in data set identification stages for many domains and about to start new code submissions for housing once we wrap up these sets. Next slide, please. Next, and this is our little map of how we develop our community terminology. I'm sorry, there was just a very loud noise in my house. Hold on 1 second. So we start with the pre-work, and then we identify codes. We collectively review codes, and then we vote on the codes, and you'll see that voting process is pretty significant here today. We then build the codes into our terminology standards. We're actively working right now, for instance, with SNOMED CT on our food insecurity terminology. Up ahead in the work in the pilots, we'll be testing this code, and then when a code that's live, and then we evaluate the effectiveness of the code that we've proposed, and then loop back and make sure that we refine code as necessary in order to make sure it fits both the semantic intention and practical purpose. So we have a question, how can I join the technical group? So there's a link up above for the HL7 work group, which is, the community represents the intersection of terminology and tech, but if you want to specifically join the HL7 work group, it's one of the links above, so that you can join at 4:04, it was the HL7 meeting calendar, so you can join that work group. Next slide, please. Any questions? All right. Next slide, please. One of the things that we've been thinking upon as we kind of unpacked some of the conversations of our previous meetings was how to address terminology that crosses different subject matter expertise. If you remember, when we were talking about inadequate housing, we had lots of conversation about environmental pollution. As we were talking about inadequate housing, we started to dive into concepts of inadequate water supply and water toxicity. So because we do not have the subject matter expertise necessarily as according to our model to address those domains, we're just basically making a statement of intent here. If we touch upon concepts that cross domains, what we're going to do is build space and pause on the build for that domain. However, the goal is to ensure that the structure of the code we're suggesting, the taxonomy structure, allows for additions in time. So we're basically creating like space, blank space for these concepts, not building them out yet because we don't want to build something in one area of the taxonomy that's better addressed in another. But we consider them and kind of hold place for them and then put them in the parking lot specifically to ensure that we address them in future domains. You heard me say that verbally on the last meeting, but I think it's really important to know that we are accountable to our subject matter expertise. It's part of what grounds us in the evidence. So if we hit upon things we don't feel like we have the subject matter experts to address well, we're just going to press pause, create taxonomy structure for that, and then not build it into code or into the data set yet until we have consensus from the subject matter experts as well. Any questions about that? So Rita's asking, what are examples of concepts that cross domains? So again, so if we think about inadequate housing, one of the things we were talking about with inadequate housing was contamination of the soil around the home. That is not a concept that's directly covered in the HUD approach. to housing adequacy. And so it's very, very important. And we talked about it quite a bit, right? But we did not or do not have environmental contamination and toxicity experts in our subject matter expertise at this time, and did not feel comfortable weighing in on that at this time. So pause, know that it might need to be added, and know that our structure can add it in the future if need be. Another example was the water, the lack of potable water that we were talking about again, in inadequate housing. But really, issues of water safety and water potability are best covered under the Z59.4 area of the taxonomy. So it's best to kind of pause and then gather the people that can help us do that well, so that we make sure we're not building code into the wrong place and with the wrong evidence behind it. Is that helpful? Okay. And understand, again, the goal is to create the architecture that will allow us to add code in the future if need be. Next slide, please. All right, some inadequate housing concepts updates, which are a slight change. We did mention this in an email. Next slide, please. So the big thanks to our housing data element submitters. So grateful across all of the different domains: inadequate housing, housing instability, and homelessness. And we're just very, very grateful. Next slide, please. Carrie, if we find toxic experts for this in our state, would that be useful? Yes, it would be. So we need to kind of add that item to the parking lot, to that slide. And then, oh, thank you, Hasna. And then gather the expertise to address it well, just to make sure we're doing our due diligence. So Carrie, send us whoever you can, please. Yes, that'd be awesome. So this is our submission summary. Next slide, please. Lovely, fantastic, thank you. These are our inadequate housing screening summary tools. It's a nice trim list because it's kind of a underexplored domain, so there's not too many. Remember, food insecurity, we just had a cacophony. Next slide, please. These are some updates. So this is where we were the last time we met. We had a really, really robust conversation regarding water potability, regarding unhealthy housing, regarding substandard housing, regarding the toxicity and the environmental contamination. And then we had a meeting with HUD. And Linda can attest, they asked us to just pause for a second. And again, this is what I'm trying to express. So next slide, please. So they were very worried about the unhealthy and inadequate housing dichotomy because they felt it was semantically unclear, given that inadequacies are also unhealthy, and there's a spectrum of concern within them that doesn't necessarily create a clear strata from inadequate housing to unhealthy housing, the way we had framed it. Even though unhealthy housing was clearly in the literature, it was their ask, and I think it actually creates a much clearer pathway to just put it all under inadequate housing and then specify more clearly our intent in the code. We did change lack of potable water, as I was saying, to lack of adequate plumbing because of that crossover with Z9.4, lack of adequate water. And this is again in conversation with our colleagues at HUD. We did add internal to environmental hazard to specify that these are internal home concepts, so mold, lead, asbestos, etc. And this will allow us, of course, if we decide substandard housing due to external environmental hazard is contained within inadequate housing, we can build it in time. Again, our structure allows for expansion. Our intent is to create things that we know we can stand by. So this is where we're going right now. We did send out a little update in an email to try to prep you guys, so it wasn't a total surprise. Any thoughts from this? Roberta likes the changes. Thanks.
Sarah?
Yes. Hi, Lucy.
Hi. Substandard housing due to lack of adequate plumbing. My mind leaps to Flint.
Exactly.
I'm wondering whether lack of inadequate plumbing describes what happened there, which I don't think it does. So what does describe what happened there?
So that is when you're still in ZP 9.4. So that is adequate plumbing has a definition that's literally about the parts, right?
Yeah.
So inadequate housing in ZP 9.1 is about parts, right? So again, I have to pause it because the moment we're talking about Flint, we're talking about contamination and toxicity, and we don't have, our amazing Flint pediatricians and our team to help us do that well. And we will gather them. And it sounds like Carrie Nichols has some folks as well. But as currently described in the literature, it's contained within ZP 9.4 and coupling it with toxicity codes, right? So you have the actual effect on the human, which is the toxic effects of the lead. Right, and then you have the ZP 9.4 code as well. And I do want to remind folks that we did ask for a splitting of ZP 9.4 lack of adequate food and safe drinking water into lack of adequate food and lack of adequate drinking water early on in our work with food insecurity, and that parent we're definitely standing by as part of our ICD-10 submission. So is that no? So food insecurity, for example, is contained under Z59.4 as it stands. So it's about the experience of the individual. Oh, and then we have some other questions about. Oh, so shelter to shelter, that's actually contained more so within the housing instability and homelessness data sets. We're specifically focusing right now on housing quality issues. It's a little bit confusing, but we have the housing instability and homelessness data sets. It's been complete for some time. We just need to vote it through, which is why we're kind of changing our processes here. And then we have the housing quality set that we're talking about right now. Homelessness have a lack of, oh, okay. Oh yes, there's many codes that would cover them. Yeah, they don't, yeah, there's a whole, yeah, this, by design, the HUD housing survey does not cover homelessness because there is no home to cover, right? So by definition, HUD approaches to housing quality do not cover individuals who do not have a home. Yes, yeah. So Hassan, I think that this is true. Is eventually, and this is what we were wrestling with last time, is we might have to have a description of toxicity and contamination, which is actually about the dwelling. We just don't feel comfortable saying that quite yet. Are there developmental components under inadequate? I'm thinking about broadband. Oh yeah, so we are. We do have space for digital inequity and utility inequity in future domains, but they're not covered again by HUD standards and within this standard as it stands right now. So okay, I think we're good. Any other questions? Again, I apologize if I'm missing things. I'm trying to go over the chat. And again, so we have to collectively, I think once we get through this 12/4 deadline, I really want to spend some time in a future meeting crafting the space, kind of the eco map of the domains to come that have yet been put on the timeline to make sure we're getting it right. And then we can do a crowdsourcing of our experts to make sure we have the right people on the job. Next slide, please. All right, questions? We've been fielding questions. All right. Okay, next slide. Oh, so are people comfortable? Well, we'll see pretty soon, but I'm hoping people are comfortable with the changes with the inadequate housing data set. We do have to reference and anchor our orientation with our federal partners, especially when they're such research experts in housing quality and homelessness. So it was a very important call we had with them that kind of grounded our orientation for now. And here we go. So we're going to try our first online vote. Next slide, please. All right. So we, in the past, with food insecurity and an attempt with housing instability and homelessness, we've had a confluence-based voting system. It was very difficult to get a quorum from our committed members with that format. I think that's partly due to the fact that many individuals sign up as interested parties because we're all interested parties, or as committed members. But that doesn't mean that you're necessarily attending the calls or following the emails, and no amount of crowdsourcing completion got us there. So we wanted to develop a system that combined the capacity for committed members to vote and the capacity to just leverage those who attend here, those who are in the meetings, who are with us working through all these different things. So we're moving from a virtual voting period to this live voting. And again, we announced it at the previous call to make sure everyone was aware. We have been therefore asking for most comments to be submitted as part of the end-to-end review so we can integrate them into the sets, and everyone's been really good about that with the inadequate housing data set. The housing instability and homelessness and inadequate housing data sets are all going to be voted on today. So you're going to see a little polling questions as part of the WebEx, and you can vote. Yes, there is an element that asks for if individuals are in any eviction foreclosure processes. There's we created a space for a code which is at risk of homelessness, and then there is there's all kinds of concepts in there at risk of eviction that you can see in the diagnoses. Some of the codes, not all of the codes in the housing instability and homelessness data set are going to be built into ICD-10-CM because we didn't think we had the literary based heft to ask for that. But there are SNOMED codes for almost every subdomain element. So there are going to be inclusion terms that will be able to be evaluated globally in ICD-10-CM, but specifically in SNOMED.
Sarah, if we've already voted, do you want us still to participate in this poll now?
No, you don't have to, but except for the fact when it comes to the inadequate housing vote, if you voted in both, only vote for those you haven't voted for. That's the easiest way to say it, because we've already logged your vote, right? And this is just
that's asking a lot that I have to remember, or maybe some other people are in the same situation that I have to remember what I already voted for.
We've already logged all of your votes, and there were so few votes that if you want to vote twice, we can reconcile it. It's all good.
Okay, thank you.
Yeah, we'll adapt.
Sarah?
Yeah?
It's Linda.
Hi, Linda.
They should have only been voting on housing instability and homelessness because we didn't start consensus for inadequate housing till today. So that would be the only one.
Linda, thank you. 100% true. So none of you have voted on inadequate housing yet, because that's today. Some of you may have voted on housing instability and homelessness. If you have a duplicate vote in that set, we can fix it.
That's helpful, because I know I voted once and I got confused when you mentioned possibly two. So thank you. Okay, over and out.
Thank you, Linda. And then there's all kinds of interventions. So if somebody has a specific question about the housing data set, maybe we can have a meeting after the fact, because there's all kinds of elements in there that are contained in there that I'm happy to walk through with somebody. So Sarah B, is the next slide the poll? Are we ready? Oh, next slide is actually a description of voting. We just want to go through one more. Sorry. Yes, Sarah?
I was going to start a poll at the next slide. So once we get there,
great. Okay, one more comment. I just wanted to give an orientation on what the votes mean. And she's you can see this here. So a yes means not necessarily perfect, but better to move forward than to block the deliverable. Yes with comment is that it's a yes forward, but you want to maybe say something is missing and you can send it to us in an email. This is a really, really great way to go forward if you really feel like something's missing, because if something's simply missing but the general structure is correct, then it's not necessarily a formal objection. It's just like, yes, but this. And if you feel like that you want to make sure a concept is included, yes with comment is a really great way to go forward with that. And again, the comments will be, you can submit any concept to Gravity projects over the course of the next week. Formal objection is, I do not agree This it's a formal process, and then basically we have to reconcile. We have to reconcile formal objections. If you have a formal objection and you want it to be counted, you need to submit a comment about what that formal objection is regarding. And again, that needs to be done by November 5th, and then abstaining is just abstaining. A formal objection without a comment is just an abstaining. Next slide, please. Again, so I just went through all the same things that she did. So this is the same slide. It's a bigger version of all the different comments. Yes with comment. Again, email your comments if you have them. Formal objection, email your comments if you have them. And if you do not email comments, it becomes an abstaining. And abstaining is a member declines to vote. All right. So you should see the poll in the chat on the side, right? That's the goal. And then I'm just going to go ahead. And then everybody should vote and submit their votes, and we'll start collating them. I'm going to give everybody a couple minutes just to put their vote in, and then we'll keep on moving forward. Are folks comfortable moving forward? Have you logged your votes? I want to give space to this. It will, the poll. I love the, we vote on the high level. Yeah, so you're voting on the data set in specific. And I do want to say, like, if you think everything is great, but I have some questions on goals, that's yes with comment. If you think everything is great, but I'm concerned about this, that's a yes with a comment. So you're voting on the high level sets, because remember, we have these master sets with all these different kinds of activities, screening questions and answers, diagnoses, goals, and interventions. You're voting on the set as a whole. And the cool thing is, eventually those sets become value sets in that will be able to be available in VSAC once all the code is built into terminology. I think we're good. Can we move on, Sarah B? Oh, about 60 out of 86 people haven't voted yet. Okay, so if you have not voted, we still are missing, is there a way to display the sets in the screen to the left of the voting panel? We could try that. It would be very overwhelming, I think. I'm going to be perfectly honest. We can, because they're massive. Maybe we can link them in the, chat. Only because each of these different data sets has 4 different tabs, right? But I'm happy to send them personally. And again, forgive us as we try to figure out this process. This is our, how are we doing, folks? Do we have, how are we doing on our votes? Our N. We can hold you hostage. This is the thing. This is what we can't do by email, is ensure that we get a quorum. EMI team, are we able to move forward?
Sarah, I just noticed that I can vote myself as a committed member. I didn't see the submit button, so just yeah. So just make sure you submit. If you scroll down the poll, like if you have it on the side, you may think that you just click it, but you actually have to hit the submit button.
Thanks, Evelyn, for these little tips. How are we doing, Sarah B?
We can also follow the HL7 process that if we don't get enough votes right now, we will call, as they do in HL7 workgroup meetings, is if you vote, your vote is counted, but you can also, if it's not, then you would be counted as abstain unless you have a formal objection. Or you notice it.
Yeah, and that is in our operating guidelines. So the most important thing to log is even if you're not a committed member, go ahead and vote. That's absolutely fine. It's important to log just some kind of you can vote. This is a new process, so we are including the votes of non-committed members. And I just want to say, the most important thing to log in this time is any presence of a formal objection. So as Evelyn's stating in our operating guidelines, any absence of a vote is assumed to be an abstain. So I think it's okay to move on. I do not want to hold people hostage because we have a lot more to cover. Does it seem fair, Evelyn?
Yes.
Okay. I want to thank you all for not only being a collective that collectively shapes language, but a collective that collectively shapes process. So we are a young group, and we really just want to make sure that our processes remain as consensus-based as possible, and that each of you feel like you have a voice. So very, very grateful for all of your efforts and your voting. If you have feedbacks regarding this process, please let us know. We mirrored this process, I should say, on a research on cooperative voting processes for food co-ops. In my former life, I was a farmer, so I interviewed all my food co-op friends, and we tried to create a process that mirrored what they utilize in cooperative meetings. So thanks again, folks. We'll have a tally on how many folks voted in a little bit. And now I'm going to keep on going because, again, there's a lot. Again, thank you so much for helping us close out the housing instability and homelessness and inadequate housing data sets. This now means that we can go forward and start working on build. We'll resolve any comments and formal objections in time. Okay, next slide, please.
Why are you so far back? I couldn't find you. Where am I supposed to park? Right there? Well, I couldn't find you.
Hey, Evelyn.
Why didn't you wave me down?
It's not
Okay.
me.
Next slide, please. Oh, is it not Evelyn?
No, it's not me. Not my kids.
I thought it was the time, so excuse me. Next slide, please.
Can we go to Target because I need to get my clothes for the
Sorry, can we put ourselves on mute if someone is not speaking? Thank you.
Although we all completely understand the complexities of being working parents in a pandemic, and we're grateful you're here. Just a note. Okay, so we do have a comment there, which is true, that maybe it's important to create a submit button for each question. Jane, that's actually really lovely. It's a really great idea. We'll try to integrate that going forward. Okay, transportation and security concepts update.
So, Sarah, wasn't there another vote? Aren't there 2 housing votes today?
There's 2 different areas to vote on in the poll. There's a housing consensus data set and an inadequate housing one. The same questions. It sounds like you have a similar question to Jane, is that maybe you saw the top one?
I didn't. Okay, I'm sorry. I only voted on the first one.
Oh, well,
I had to scroll. Oh, I didn't realize. Thank you. I thought it was going to be a whole nother vote. So here I go again.
You're lovely. Thank you so much.
And now I can't. It's been deactivated.
So if it was deactivated, if you can just simply put your comment on data set number 2 for inadequate housing in the chat, we'll count it that way.
Thank you.
Anybody who missed that, and again, learning, Sarah DeSilvi, it's important to clarify when we're doing 2 concepts at once that we either need to build separate questions for each data set, which is probably tidier, or we need to clarify that in our instructions. So I apologize. Thanks, everybody. Okay, Transportation insecurity concepts. Next slide, please. If folks can mute, that'd be great. Again, huge thanks to our SMEs who've been helping us along the way. So Jennifer Sisto Golf and Lift, Dr. Epoch Center from Texas A&M, Alexandra King from CTAA. Oh, and I forgot to update Michael Adelberg's commentary on who he is, but he's from Fair Consulting, and we've been meeting fairly regularly to try to work through transportation over the last bit of time. And I have to build a little pause. So first of all, thank you everybody for housing instability and homelessness and adequate housing. I don't know if I said that loud enough. I think I'm so concerned about time that I just wanted to make sure I give space for recognizing that collective labor over the course of like 6 months. So thank you, everybody. So, so grateful. This is truly a collective work that we create together. So grateful for all of your effort. Okay, next slide, please. This is the status on transportation data element submissions. Next slide. Again, I'm just going to remind folks on transportation insecurity screening approaches. Thanks, Julia. Speaking of Prepare, so Prepare is our first question and answer, and then we have the Washington Association of Community Health questions, health leads, and WellRx. Next slide, please. That's great. You can see here that we are recommending only one concept going forward for ICD-10-CM, but you can see that there's a lot of different subdomains that we're parsing out in our SNOMED CT work. The idea, and this will probably be familiar for folks who are with us with food insecurity, is to create subdomains for every measurable and distinct element of the meta concept. So we referenced in our food insecurity work often the work of Dr. Coates from Tufts, who publishes quite extensively on food insecurity measurement. And then if you all remember, what we did is utilize all those elements of measurement, both in recommendations for code and in recommendations for a definition. So you can see here on the SNOMED CT side, all these different subdomains are parsing out. So transportation insecurity is defined by inability to access health and social needs, inability to access health appointments, pharmacy, food, etc. And then we also have a concept we're working on as available transportation does not meet an individual's functional and cognitive needs. We have a concept of excessive time spent traveling. This is specifically significant when it comes to living in rural areas and access. There's a very simple inability to afford transportation. There's elements of how distance to destination limits your available transportation options. And then we have decided to build a concept that you're of dependency on transportation assistance. You can think this being very, very relevant for things like patients who require non-emergency medical transport to rides through dual insurance or Medicaid. And then we're also working on concept of captive transport, individuals who only have very few options. So again, this is all a work in progress, but heading towards 12.4, we have just that ICD-10-CM code. Next slide, please. So we recognize as part of our responsibility whenever we're doing diagnoses, terminology to create appropriate diagnostic definitions. So this is a large part. Okay, so can you explain why only one ICD-10 Z code is being recommended? Deb wanted to know that before we go forward. There's an incredible, well, first of all, the transportation insecurity science is quite young. So food insecurity is probably the most far along when it comes to social risks and understanding sequelae on health concerns. We can imagine a future time when the SNOMED CT codes that we're proposing have been tested in practice, that we could go back and expand again upon that transportation insecurity parent. But for right now, the experts that we have across policy and clinical practice and research feel like at this stage, the ICD-10-CM code is going to be just the parent, and then with a capacity to expand in time. Is that a suitable answer? And again, if the community is adamant that that's not sufficient, that's what the community is for. If the community wants more granular codes, that's entirely reasonable. One of the things you think about that might be important is that dependency on supportive transportation. If you're trying to analyze, for instance, all your patients who utilize NEMT in claims and not just in other terminology. But so that was the approach there, just as a reference.
Sure. It's Deb Donovan. Just to share a different perspective. I'm imagining for the health plans as they think through the development of supplemental benefits and are trying to understand what type of transportation needs they're solving for, to know what kind of benefit plan to structure. The kind of that broad helps us know there's an insecurity, but it doesn't help to distill down any further insight so that we know and use that, submission through claims to kind of discern what our populations are experiencing to inform our benefit designs.
So I wonder if we can go back one step to the previous slide. I wonder if we could digest this slide here, right? And again, not necessarily, you can think about it, right? And if there is a subdomain that rises to the top when it comes to analyzing type, just let us know, right? Because we would be happy, anything that we propose in ICD-10 CM, we have to, of course, create a standard definition for it. And so that's where the next slide work comes in. But if there's something that seems significant from your experience practically, this. So just let us know. And then Jen's piping in. Thanks for coming, Jen. So one of the things Jen's referencing is that we have very clearly across all of the social risk domains demonstrated a need to build panels that describe eligibility and enrollment. And we talked about this in food insecurity, and we've talked about this with housing, and we've talked about this again with transportation insecurity, that maybe this would not be in claims, but it would be a LOINC embedded panel that would say whether a patient qualified for everything from SNAP, or whether and then they were enrolled in SNAP or WIC, or shelter options within the homelessness and in housing instability data set, or Section 8, or any of the different options, and developing encoded panels that we can agree upon that describe eligibility and enrollment. But if that doesn't seem sufficient, and you feel like that ICD-10 code is necessary, please highlight. And again, Jen Sistergal is one of our SMEs and brilliant when it comes to the intersection of policy and transportation. And I was also an HIT whiz. So just let us know, Deb, if there's something that rises to the surface.
Okay, thank you.
Sarah?
Yeah?
I'm going to try to voice something. I'm not sure that I can completely capture it. But if someone has transportation insecurity and they are offered something, one use case is going to be that they want to combine getting things done with that one offer. They want to go to a medical appointment. Mm-hmm. They want to go to the grocery. They want to drop something off at a friend's or at a family member. Mm-hmm. Is that something to take account of? In other words, whenever you offer this benefit, I don't want people to be perceived as, quote, taking advantage, unquote. I'm wondering if we can somehow capture that transportation insecurity could be really fundamental to life. And if offered a transportation option for any single reason, the reaction is going to be, but couldn't we please do these other things?
Yeah, so maybe Jen can unmute and help us parse through that, but that was in the original Kickoff. Those access to other social needs was part of the framing. And this is kind of how we, you can see this attempt inability to access health and social needs, like pick up food from the grocery, right? Pick up your medications from the pharmacy, right? Yeah, so we have been very intentional to include that perspective in our approach. Jen, are you able to unmute and speak to that anymore?
Could you repeat the question a little bit?
Oh, God.
Just.
I guess what I'm trying to envision is a use case where building on what Deb just said, we want to offer transportation as a benefit or an incentive or however we frame it. The point being, we're offering transportation for health reasons, but when we do that, whoever is missing transportation could seize on that to do a lot of other things besides pick up the meds or go to the doctor. And whether that is something that we can capture in a code, let alone capture as a benefit, maybe it's just too complicated and doesn't really fit with insecurity. It's more how one reacts to insecurity when offered something.
Sorry to jump in there. It's a wonderful point. And when we think about transportation interventions and kind of addressing co-occurring social needs. So for example, if part of your benefit was a trip to the grocery store, but when you get to that grocery store, you're actually getting physical activity and social interaction, right? Those are second order, I would say, impacts. Very hard to measure. But I think it's it's a fantastic point. Agree with Sarah that it's been in the framing. I think one thing is that it really will depend on the program, right? So oftentimes, like in Medicaid and EMT, right, the largest funder of these types of benefits today, it's going to be a predefined trip that's going to be just from, home to your doctor's appointment. So I think there's a wide variety of benefits and programs, and we don't want to just look at it from that lens, but just to give you an example of, some programs are much more scoped in terms of what the benefit actually is versus some that are more flexible. So I think it's a great point. I think we discuss it. I think trying to understand how you'd bring that back into the data, research, and outcomes is tricky, but we should continue discussing it.
Thank you.
So I'm just trying to answer as many questions in the chat as I can. And so again, I think we do have some of our SMEs on the call here today. So I think, again, specifically if you have ideas of things that you want to have called out, we can bring them to our conversations in the next weeks or so to try to see if we can get this into the 12-4 submission. I do want to state, though, that by simply having this parent, we have the capacity to expand it, just as we were talking about with some of the earlier concepts. So we'll try to achieve consensus on whatever we can ahead of 12.4, and then know that simply having a ZFE 9.82 code is a huge win. So we'll try to see if you have specific ideas about what's necessary, we can bring that back to the group. Does that sound good, Jen?
Sounds great.
Sounds great. All right. Yes, yeah. So the economy of needs. Oh, look at that, the trolley option. Okay. Okay, so again, this is the work in progress. So if you have specific ideas about diagnostic approaches, let us know. Next slide, please. And again, part of what we're doing right now is trying to figure out how to define these things. So in the center is a definition from the literature: unable to regularly move from place to place in a safe and timely manner because one lacks the resources necessary for transportation. Up on the top is a definition that we're working on that's built off of our food insecurity definition. It probably looks familiar. So uncertain, limited, or unstable access to transportation that's affordable, equitable, sustainable, and resilient. And one of our SMEs is really asking us to kind of sit with this, what it means for things to be sustainable and resilient, appropriate. And then we added meets functional and cognitive needs and is safe and acquired in socially acceptable ways. And then a synthesis definition offered by one of our SMEs as well is lack of regular access to vehicles and devices that permit a person to reliably arrive in a safe and timely manner at sites necessary for maintaining that person's health and well-being. This can be due to the ability to utilize available transportation, lack of available, reliable, or appropriate transportation, or inability to pay for available transportation. So all of these are being refined in our basically seminars that we have. All of a work in progress. If you have any insight into definitions, please let us know. But again, akin to much of our work, there is no formal definition for blank. And so we are responsible for defining a definition that meets the use case of our needs, which is defining these concepts for the individuals we care for in clinical practice. Let me just make sure I didn't miss anything. Yes, so sometimes the available option does not allow for all the desired riders, i.e. extended family members for appointments. True. And then we are not completely ignoring environmental impact. In fact, we talk about that a fair bit in our subject matter expert huddle. That's a tricky one, but we actually did talk about that a lot, Lucy, I promise. And then context. So Jen, do you want to comment on Lucy's little statement there?
Around environmental impact, or which one?
Oh yeah, okay. So Jen, you're actually saying, Lucy, we did discuss in what the definition of sustainable meant, and then okay.
Yeah.
Anything else to say here on these definitions? Understanding that they're kind of a work in progress. Jen, do you have anything else to say, or am I missing anything in the chat?
Well, I just say the chat really mirrors a lot of discussion we've had. It's great. It's really helpful to see that you all are thinking about this in the same way, whether it's understanding the family context of transportation. You know, caregivers in transportation are really important. When we think about minor transportation, for example, as having a caregiver or a parent with them, or of course, caregivers for like elderly, for example. So I think that's really interesting. We do talk a lot about the social needs and about kind of recognizing transportation is an infrastructure, is a system. And I think that's where Sarah was mentioning our focus on resilient and kind of sustainable transportation approaches, meaning if, for example, you are dependent on public transport for your day-to-day, you know, does that still, by definition, make you transportation insecure if there was an issue with that? I think other people here have commented on things like distance and time. Those are two components we talk about a lot as well, because just because there is a bus that can get you from point A to point B, if it takes you 2 hours to get there and back to your appointment, you know, how does that impact your ability to have employees to do other things you need in your day, and a lot of time trade-offs. So just Sarah, more than anything, just echoing and appreciating the comments. I think the synthesis definition, like I think there are things with that I want to riff on with the SMEs, right? Because like my 2 legs aren't included in vehicles and devices, but I think 2 legs are always a great option for transportation. So I think we'll continue to work on it, but really appreciate all the input and feedback.
Thank you, Jen. And then do we break out what the transportation is for self or dependent, or is that done with the provider? Right now, the patient is the person. We actually have talked a lot about secondary panels that, again, assess some of the complexities of what needs to be known and shared. So beyond eligibility and enrollment in general, like questions that one would need to ask for NEMT. So non-emergency medical transportation, Jen's trying to train me, that you could ask all those questions, and questions that might need to be asked from a care management perspective and a care planning and social work perspective. So we have those conversations within our SME group and are definitely considering that. Yes, these are all, yeah. This is some of the subtlety that we're trying to describe, is sometimes the, again, whether because of the individual's functional needs or whether because of the options, the transportation that's available might not meet the needs of the person. So it's not just whether the transportation exists, it's whether it's appropriate for the needs at hand. and we go back and forth with all these different concepts in our SME group. So again, we just wanted to represent some of the labor here because we are on target to try to create a definition that's encompassing. And again, any diagnosis that we propose for ICD-10-CM needs a definition on hand. Please also pay attention to child transportation in a primary, secondary school context. I think we have time to have you unplug and let us know what you mean there. This rural PD primary care person thinks I have an idea, but if you could unplug and just let us know.
Yeah, this is just, I have been talking to many teachers who are and school personnel working with children. School context is more than just a school bus. It is getting kids who have health issues to a school-funded or school-operated healthcare, and it can be very complicated. Let's put it that way. So what I'm thinking about is school districts and their responsibilities for transportation and what kind of transportations they can actually leverage.
Mm-hmm. Yeah. This is an interesting use case we have right now, of course. Okay, we have all these things in our hoppers. Jen and I will take all these things back to this SME group. Any other considerations to make sure that we bring back as we're talking about definitions for transportation insecurity? So far we have 2 action items. One is to consider what diagnoses might need to be brought over from the SNOMED suggestions into ICD-10-CM as children of the meta code. And then a lot of things to consider in the definitions work. Yes, yeah. So we have this available doesn't necessarily mean correct for the individual. Thank you, Hasna. And then
Sarah, I'm wondering, build off the food insecurity. I know in food insecurity, we talked a lot about family and other people. Mm-hmm. And I'm just wondering, based on a lot of the chat here, I think the point about someone else has to go with the patient is really critical. And so I'm wondering if the definition here needs to specify we're talking only about the patient, or we're talking about a patient who won't go anywhere without someone else, or a patient who can't go anywhere without someone else. The minute we're talking about vehicles and devices, to me, that evokes only one person or more than one person. Not sure how to capture it, except to say at the outset, we're only talking about one person. Please don't talk to us about they need a translator and they're only going to consider their child the translator they will talk to, or something along those lines.
Lucy, I'll just say, and Sarah to jump in, I completely agree. I think when in the first definition, when we talk about meeting cognitive and functional needs and acquired and socially acceptable ways, I think having a caregiver or a passenger, just like having an ambulette or a stretcher gurney van, those are all interventions that needed to be triaged to be appropriate for that passenger. So I think I very much agree with you. I think if it needs to be more explicitly defined, I think it's interesting because we've had this conversation back and forth. Like there's a litany of considerations for what the intervention should look like, right? And I guess, yes, I don't know if it diminishes it enough to say that's part, or if it diminishes too much to say it's part of the intervention, but it's definitely something that we've talked about extensively.
Great, thank you. Somewhere.
Mm-hmm.
Okay.
Okay, so we have a question here about adequate transportation network. So this is where we cross over between individual. at this moment, we're thinking about the individual navigating their environment. We will, in time, have to figure out how to describe the environment itself. And I don't know if Jen, if you want to riff on that a little bit, but similarly to food and housing, we're trying to think of these concentric rings of what is secure for the individual and what community, transportation, and security would look like as well.
Yeah, I agreed with your kind of initial side there. It's a lot to unpack. Charlie, I think that you can think about your adequate transportation network from a community perspective, but also from whoever's managing the transportation benefit. So if it's a state Medicaid agency, if it's a health plan, if it's a transportation broker, they have a very defined transportation network that's just like a provider network. And within that network, they have to have all different levels of transportation modes, right? Cost effective and appropriate for that individual. But certainly from a community perspective, when we have like Alex back from CTAA, for example, she could provide a great definition from a community infrastructure perspective. But I think we have those two lenses, like what's adequate just from a transportation infrastructure perspective and what's adequate from meeting the needs of a certain benefit and who's administering it.
We do try, as best we can, to frame these conversations out in our conversations, though it's incredibly complex. Safety of public transportation. Okay, I think. Okay, is there anything else? So this is all incredibly helpful to take back to the group. We have talked about safety. We did, this has reminded me of Hasna's conversation where she was talking about navigating from your apartment to the subway, considering those elements of neighborhood safety. And again, we always just want to make sure to frame that as we try to sort these things, to develop language, we recognize that these social risks are a Venn diagram of overlying experience for the individual. And we just do our best to try to figure out how to sort it out. I think that there's a lot here to take back to the conversation. There's still a lot to cover. So if it's okay to move forward, we still have to cover a few more domains before the end of before the half hour. Or is everyone okay with moving forward? Sounds like.
Yes, please keep overwhelming us.
Oh, I'm sorry. I'm sorry if you're overwhelmed. We try not to overwhelm, but if anything needs to be unpacked offline, I really am here to try to help. You can always write me an email. Our SMEs are incredibly generous with their time. Just let us know if you need anything to help frame this going forward, Lucy.
Yeah, and Sarah, just a couple final comments on the question about network and coding in an EHR, right? If you think about if there's an inadequate transportation network from a community perspective or fulfilling a benefit, that could very much end up in a missed appointment, right, on the provider side. So just think really, and then, Hasna and Charlie's comments, I think, we did, and we talked a lot about safety, time, and distance. So when I mean time, it means, yes, if there's only several modes of transportation and they're insufficient in terms of scheduling or the amount of time it takes you to get somewhere, that was something that we wanted to capture in terms of uncertain, limited, or unstable. So yes, just to say these are awesome and really appreciate it. And Charlie, your question on how to track the level of enough, I think that's where I think Sarah, like getting Alex's perspective on how, for example, CTAA does that would be really great.
Mm-hmm. And I do want to state, though, in general, in just a general statement, and you'll see this again as a theme, we recognize the temporality, like cyclic, intermittent, chronic, all kind of influence each of the social risks we're talking about. We're not focusing right now. We were just having this conversation with the financial strain SMEs on pre-coordinating that, like building all of those temporality elements into the terms themselves. But we recognize the need to define these things somehow in our documentation to add modifiers of temporality, because especially with economically driven concerns, there's often seasonal, monthly rotations, or like a dance that these families go through, these individuals go through. So just know that in our definition, you see these, you see stability there, right? So whenever there is a temporality element, we're still keeping it in mind across all the different domains and trying to figure out how to allow for documentation for that in the future. All right. Next slide, please. Again, this is just the brainstorming slide we always see. Next slide, please. This is still a pitch to treat. Please submit goals, interventions, which include programs and their definitions, people and professions. One is Alex suggested was the mobility manager, and their definitions. So whenever you submit something, please do add a definition. And Charlie, thank you for your collaboration offer. Yay. And then any activities in their definitions. You can always submit on the Confluence through the submission link. Next slide, please. Okay, I think we covered questions, so I'm going to try to keep us moving because we still have a fair bit to go. Next slide. Financial strain concept screening and diagnoses. So I've had some really intense meetings with our financial strain folk, and you'll see some evolution of concepts over the next few slides. Next slide, please. Again, our subject matter experts are Dr. Adam Shikadans, Dr. Andrew Pinto, and Dr. Jeffrey Colvin. I'm grateful for all of these fellows who came to us through our connection with UCSF Siren. Next slide, please. These are our existing definitions, which we have to bear out whether they're appropriate for the use case. We're doing that right now, but this is the definitions we found from the literature to kick us off. Next slide, please. These are some of the screening tools. Again, the cardio screen, prepare, AFP, health leads, and BRCIC, which I'm suddenly forgetting the name of. But it's just a general, do you have trouble making ends meet code? Next slide, please. So this is actually, I'm sorry, we go back one different slide? Excuse me, I forgot to mention something. I just wanted to reference here the different types of questions that you see here. So you see Cardia is asking, how hard is it for you, right? And you would have an answer of a not hard to very hard, right? Prepare asked, have you been unable to get any of the following when it was really needed, right? So that's actually an access to the thing. AFP asks, I don't have enough money to pay my bills, right? And some of these questions, so Carrie's right. So I've struggled with these questions, even some of our food insecurity questions as about money. So again, we do our best to group things when we feel like they're relevant to the domain, but you can see some of them ask very different things. And this is kind of what I want to highlight here. Health Lead specifically asks the questions about accessing doctor's appointments because of cost. And understand that financial strain is this huge bucket where many of the concepts we describe in our previous domains are contained under. And then we have sometimes people find their income does not quite cover their living costs. Has this happened to you? Again, this is a meta question. And then do you have trouble making ends meet? Again, it's just, are you experiencing difficulty or strain? Now, next slide, right? So this is what we have so far when it comes to income and diagnosis codes. So we have the extreme poverty code, we have low income code, and some pretty critical things are missing. So poverty as a concept, which is in between low income and extreme poverty, it's not there. Financial strain, which is different than income strata, is not there. So financial strain is across all income brackets. You can feel the heat of trying to make ends meet and not be either low income poverty at the federal poverty level or extreme poverty. Material hardship is not on there, and that is I can't afford enough, if I don't have enough money to buy clothes, to buy this. So when an income actually affects what you're able to purchase and bring into yourself. And then specifically, there's no elements of medical debt and financial limits on medical access. So there's a lot missing within those two codes. One thing that we noted is that there are very few instances, well, there's not very many instances where you are actually measuring income level. There actually are some really lovely tools that do this. The work of NAC comes to mind. But we do have proxies that we utilize and when we consider these terms, such as qualifying for free and reduced school lunch, WIC, or Medicaid. And this is all dependent on policy, of course. Qualifying for Medicaid in the Valhalla of Vermont, where I live, is different than qualifying Medicaid in a state that did not take the Medicaid expansion. But these are just things that we think about, because whenever we think about diagnoses, we actually have to think about whether it's measurable, right? So how does a clinician define this concept? Okay, next slide, please. So again, just a little caveat. So some of the things we think about when we are building is whether there's crossover into other areas of ICD. So there already exists this code, patient's intentional underdosing of medication regimen due to financial hardship. This is a child of patient noncompliance, which is problematic and not patient-centered. So if a person was experiencing financial hardship and it had effect on ability to attend appointments because of copays, it would be a logical sibling of that code, as you could see as it's structured. And Carrie, yes, so there are concepts of medical debt that are specifically identified in the literature that that will be the reference definition for that concept. So it's not just all medical debt, it's medical debt affecting the individual in specific ways that are evidenced in the lit. So the statement on this slide is this concept, we're working on it right now to try to figure out the origins of it. Where did Z91.120 come from? Is this the correct place in the taxonomy for this code? And this little work in progress means that financial hardship affecting appointments is on hold as well as we work on this structure, right? We need to figure out the origins of this Z91.120 code, and then there might be a little challenging to the ICD-10 Coordination and Maintenance Committee meeting to try to figure out if this is actually the correct place for this. So concepts of financial hardship and how they affect ability to attend appointments and copays are on hold for a second. Oh, probably more than a second, a little bit. Next slide, please.
Sarah?
Yeah?
Yeah, before you leave the medical appointments,
okay.
I'm wondering, we all know that dealing with financial hardship is could consume us for the next year. So I'm wondering whether connecting financial strain to something that we all agree is necessary or needed is a way to get our hands around this. Like, you may not think you have enough money to do what you want, but I, as a provider, hoping to intervene and improve your health status, do you have enough money to eat, to pay the rent, to buy transportation, to get to your... So I'm trying to think about how to limit how we think about this, since it's really a limitless topic.
Well, maybe the next slide will help.
Oh, okay.
Maybe.
Great minds.
So I don't know if it's going to help, Lucy. You can let me know, right? So again, each of these concepts, the subject matter experts state very clearly are definable, measurable, and have common questions and answers that could lead them to them. So we met and I was like, you have to defend each of these comments. Like, is this necessary? And can we get to it by 12/4, right? So this is the proposal they have so far, right? A general concept for financial insecurity. Lovely, vision cost burden, great. I'll add that to the pot. A general concept for financial insecurity, which is easily covered by the concepts that we saw in the AAFP tool and the cardio tool and the BRCIC tool, like difficulty, right? Having financial difficulty. and specifically addressing concepts of medical, dental, and now vision and hearing, cost burden within that for direct action from the clinical side, right? And then they were very careful to say they did not feel that material hardship was a child of financial insecurity. They wanted it in its separate level, right? And again, akin to the UHC AMA submission, they felt like it was justifiable to parse out any material hardship that wasn't covered in a different domain. So right now, the proposal is to go forward with concepts of financial insecurity, medical cost burden, and we'll consider vision and hearing and DME. I think we might be getting too granular with some of those because I think DME would be contained within medical most of the time, at least from a clinical perspective. And then material hardship codes for a set of core concerns that affect families from the literature. They also wanted to create a concept for debt, which is a general parent, which would allow expansion to include medical debt in time, but right now it just sits there. And again, all of these feel very comfortable saying are defendable and definable by 12.4. Any thoughts on this? So is partial coverage in that same domain is not covered? I'm trying to figure out what that means. Is partial. So financial insecurity would have this same household level measurement usually as food insecurity. So if the caregiver is financially insecure, that would apply to the child as well. Why are material hardship and debt not subtypes of financial insecurity? Monique, that's a really good question. We had a long conversation about this, and as my meticulous friend, I would love to have you help me figure out how to convince them. Because in my mind, because what you want from a taxonomy perspective is whatever is true of the parent to be true of the child, right? So every person who's experiencing material hardship would be financially insecure. Households not always defined as a family unit, not according to the USDA. Absolutely not. So sorry about that. The idea is, yes, there would be child codes for each of those specific elements. Yeah, so Ned's asking, would there be 59.841, et cetera, and yes, there would be. Again, this harkens to the UHC AMA application. We could not build them off of low income because, again, the concepts of material hardship are not contained just to those who fall in the low income definition, according to the US Census Bureau. Yes, all kinds of debt. And so right now, again, understanding what can we defend, right? So the idea was to start with this and then allow space for expansion with future concepts. Okay. Copays can be very high. Yeah. Yes. Yeah. Household, yeah, so Carrie's saying, so roommates would be experiencing financial hardship that would fall into other members of the household. I can imagine that being particularly important right now. Yeah, so this is in the literature, again, of general financial strain. And we actually do see that borne out all over the US right now because of our twin pandemics. Oh, no. So judging by the child codes, it looks like financial insecurity really means or appears to mean only medical financial insecurity. And the answer is no. So financial insecurity is a meta bucket that includes everything. In fact, in order to do this well, we have to build exclusion terms because we're saying it does not mean food insecurity, does not mean housing instability, does not mean transportation insecurity, even though logically those are children of financial insecurity. We just are addressing them elsewhere. So I'm sorry, the definition is broad. We're just calling out these two elements to highlight them. But again, so individuals who experience medical cost burden are by nature financially insecure. However, not all financial insecurity is covered by medical and dental. So there are obviously intersections and associations with income and financial insecurity, but they are independent of each other. There's a lot of lit on this, like we can bring to future meetings. Mostly I just want to make sure that folks feel like this seems like a good Gestalt orientation. I hear Monique's question about material hardship, and I'll bring that to the group, back to the group. And yes, wealth is only in red because we are not covering that yet. I'm sorry. So wealth is a placeholder. So we know that wealth is a concept that's different than material hardship and different than financial insecurity. We brought it up in our conversation. They're just placing it there, but there is no intent to build that forward in code right now. We're just talking about it. Yes. Yeah. So that is an interesting idea. Legal cost burden is a good one to think about. Well, seems too broad now the scope. Okay, any other questions? Again, there's so much to cover. I'm a little bit worried because we have a few more things to cover going forward, but does this seem like a good orientation in general going forward? Okay. So we do have a social isolation concept coming up in early 2021. Absolutely. Okay, and again, I apologize for this late breaking financial insecurity statement. Sometimes with these codes, we think about things and we think about them, and then the SMEs and I had to huddle, and it all got redefined. But Monique, I'm going to take back the question again and challenge my SMEs on whether material hardship should be a code of ZP 9.83. And yes, wealth is very important. See, wealth is, again, wealth is a separate concept. It is not just about it like cash in and out. And so we definitely want to build space to think about that in the future. When we think about wealth gaps and we think about ethnic associations with wealth, and there's a lot to unpack there, and health associations and mobility, and wealth is an important concept we need to cover in time. Yes, okay. So I just want to quickly go through the next two slides because we need to keep moving just so you guys can see everything. Next slide, please. Again, always available for questions and answers. Next slide. Again, oh my Lord, folks, if we are going to have a submission that includes veteran status, education, and employment, we needed to get some things in front of you. So I've been working very intently with folks on these concepts in the background just to get something in front of you because, again, we're a consensus group. You all need to agree and see things and have time to digest them. So I apologize for the pace of everything, but we are trying to see what we can get in front of the ICD Coordination and Maintenance Committee by 12/4. Next slide, please. These concepts were grouped because they have very similar features. They're often screened with questions with binary answers or yes or no. They often reside in the social history section of a patient record. We just want to, again, briefly present these concepts for you all to digest on, and please email me with any questions. Next slide, please. Yes, so we do have consumer credit counseling as one of our interventions. So just a brief highlight of veteran status and veteran risk. This is just some of the literature on risks of being a veteran. Again, woefully do not have time to cover all the complexities of this condition, and we'll do so further at our next meeting. Next slide, please. So one of the things that's true about veteran status and diagnoses is that the current ICD-10-CM, even remotely covering veteran status, is pretty insufficient. So right now, the code we have is Z91.82, personal history of military deployment, but this is actually not the same thing as veteran status. There is really no semantically clear way to determine veteran status in ICD-10-CM. There is a SNOMED CT code for served in the military, which is conceptually aligned. Again, we're working with the VA on this. One of the things that's concerning, though, is that these codes are not mapped because they're not kin. So if you had problem-based billing and you use serve in the military, there would be nothing to drop a code into claims for you to analyze in claims. So that's a problem, right? So when we say mapping, we mean they're twinned. Like there's a like CP 9.4, lack of adequate food and safe drinking water is mapped to food insecurity. So you can use one and it twists and turns into the other. It's automatically translated. Next slide, please. And so one of the things that we're suggesting is a code for personal history of military service, which would allow a direct map. Interestingly enough, we're working with the VA to see if we can make a case for this new code, and we have yet to have support for that. So again, if any of our colleagues on the call feel like they personally need the case for this, please let us know, because we would need to balance the caution of the VA with community need, right? So Carrie, if your teams feel like this Z91.85 code is significant or important, please send us an email just so we can balance out. Because again, right now, there's a little bit of caution from the VA for building this new Z91.85 code because they are still trying to understand the use case, largely because they work within a system where it's de facto everybody's a veteran. So, or at least most people are. So that that creates a different use case than community providers, for instance, who share care with new VA extended primary care providers, for example. Yes, we actually have been referencing that. Thank you, Barbara Wallace. And then Jane said, with its recent veteran support services, Unitas might be a good resource. That's true. So maybe we can, we do have Unitas on our technical advisory committee and can specifically ask them and reference them and see if they feel like there's heft for this as well. So the goal of this meeting is to really get things in front of you all. And again, if we fail to make the case for this for 12.4, if we don't get there, we can always consider it in time, but it's something we need to consider collectively. Next slide, please. And then this is it. So there's just a couple other codes that we are going to go through here. So again, these are codes that are built off of, again, the UHC application and the AMA application that were by different subject matter experts agreed to be justifiable at this time. So this is the less than a high school degree ICD-10 code, and then a specific child for unemployment unspecified, which would be unemployed and seeking employment. And I want to apologize for how swift those last slides were. My word. Maybe a link to reference VA in need of food and shelter is possible to create an ICD code. I don't know if you can help me understand what you mean there. Do you mean a link to convince them or a link to, I don't know, so Denise's, I can't hear you. And then Carrie, no, in this instance, this concept would apply to anyone who has a history of service. I don't know, so I want to be able to answer Denise's question. I don't know if I fully understand, but friends, we are over time. We have rushed through these last slides, and I'm sorry because we had such a robust conversation early. At least the concepts that we're considering within those final domains are in front of you. So when we come back and revisit them, you can have seen them. If you have any questions, please let me know. Yes. Yes. Therese, I hear you on that. Next slide, please. Community homework, next slide, please. Just again, high school degree, US, and this is a US use high school degree, because this is an ICD-10 CM, because we have different terms here in the US than other schools, as you are aware. Okay, Denise is going to look up code area, email me a better question, keep going. So anyone, so grateful for your votes for housing instability and homelessness. Thank you so, so much. And then submit concepts for transportation, financial insecurity, and those demographics if you have them. Because of how swiftly we move through those last elements, please let me know any concerns. And then we have some action items regarding transportation insecurity and that definition, trying to see if we can pull any diagnoses over into ICD-10, but we need to justify them. We have some questions on the financial strain diagnoses, whether or not material hardship is meant to be a child of financial insecurity. And then we have some things in the air regarding veteran status and trying to work with the VA. Whew. Thank you for staying with me a few minutes later. If you have any questions, please email us. You all have a lovely Thursday. Thank you so much.
Thank you, Sarah.
Thank you.